Hello, everyone, and welcome to the Akkad and Koka Report. I'm Michel Akkad with you in San Francisco, and my co-host Anish Koka is joining us from Philadelphia. Now, many of our previous guests on this show have brought to us tremendous wisdom gained through years of experience. Today, we are going to look at healthcare through the eyes of youth and optimism. We are delighted to have with us the face, or a face, of the future of medicine. Our guest is a fourth-year medical student who is eloquent, dynamic, and seems to have a clear vision of the path he would like to forge for himself in this treacherous landscape we call the healthcare system. He studies at the University of Chicago School of Medicine, but also took a year off to obtain a master's in public policy. He writes frequently about interfaith dialogue, Islam, and the intersection between healthcare and spirituality. He has been interviewed by the New York Times, Al Jazeera, and PBS, among many other outlets. Aamir Hussain, welcome to the show.
Thanks for having me.
We're delighted to have you. This is terrific. I'm very glad that, to talk about healthcare from the perspective of a medical student, somebody who's, sort of fresh out of the gate, or almost fresh out of the gates. Before we start, you and I met at the AAPS meeting, the annual meeting of the Association of American Physicians and Surgeons. And I'm curious to know how you learned about that organization, because it's not very well known among medical students. I know that when I was a student and a resident, and I had no idea about it, but I think it's a very good organization that does a lot of good work. So how did you get involved, or how did you get to know the APS?
So when I was a medical student, we had a health policy interest group. So we invited speakers on different topics. And our single-payer advocacy group wanted to have a debate with someone who maybe supported the opposite position. So we actually reached out to Dr. Lee Hybe, who's from Oklahoma, and she was volunteering to come and speak to our med school. And during that debate, I became interested in hearing other perspectives that we don't really learn about in the curriculum. And through kind of conversations with her and some other doctors, I heard about the conference and then decided to come and join it.
Okay, very good. And I know that you gave a podcast recently on the Benjamin Rush Institute podcast show, and we had the executive director of the BRI as one of our podcast episode guests, Beth Haynes. And are you a member of BRI as well, or?
Yeah, I'm involved with some of their programming as well. Yeah.
Okay, very good. So, how's life as a fourth-year medical student? What's happening with you?
Things are good. I am applying for a dermatology residency, so I had to apply to a lot of programs because it's very competitive. I've just been traveling a lot for interviews. It's been kind of nice to see different cities.
Okay, and I think it's probably the same as when the same routine. There's a matching day in March.
Yeah, March 15th. Beware the Ides of March.
Okay. And where are you from originally?
So I'm from Farmington, Connecticut originally. I grew up there, and I've lived there until I went to college.
Okay. But you're applying widely, and you'll go wherever, the best match that you can get?
Yeah.
Okay. You took a year off to study public policy.
That's right, yeah.
And were you... I mean, I don't want to put words in your mouth, but it seems to me that you may have some free market sympathies, at least, in healthcare. Perhaps not, I'm not sure. Go ahead. What got you interested in public policy, and how do you view this fitting in with your career plans?
So it started when I was in college. I went to Georgetown, which was a big center for a lot of discussions and policy debates around the Affordable Care Act when it was first being passed. And I got interested in healthcare policy because I wanted to go to medical school. And I realized that a lot of doctors weren't involved on the policy level. And because of that, there are a lot of policies being made that maybe they didn't agree with. And then University of Chicago had this unique program where it was a 1 year to get a master's in public policy. And because of the strong economics background, I really wanted that alternative perspective on things. So I'm not really sure where I fit ideologically, but I'm more interested in just following the evidence and whatever seems like the best solution based on what doctors think and just general logic.
Okay, and I'm fine with that. My experience is, the reason doctors don't get involved in policy. Actually, it's not true. Some of them do, but when they do, they cease to be doctors. Frequently. I mean, it's sort of it sucks you in, and and I don't know if you've listened to any of the episodes that we've had, but for us generally, the best health policy is less. Right, less of it, whatever it is, less of it. Just tear out the pages out of the Federal Register, and we'll be happy. How do you view things, at this stage, from your perspective? First of all, how do you think you will? Dermatology is a residency program. Do you plan on putting your policy perspective on the back burner while you finish your residency, or
I'm curious before you answer that. What with your year of what did you what type of insights did you gain from the year of policy that you did?
I think that it was really important to learn kind of practical skills related to economics, but also some of the theory behind it. Mm-hmm. And I think a lot of doctors especially don't really learn this in medical school. Like we had maybe a 2-month course on basic health policy that like the minimum doctors should know. But if you want to be involved with like making policies, you need to know more about that.
So what, so we're doctors that have not spent any time in any policy school. So like what type of things should we know?
One example was a class on formal cost-benefit analysis. Mm-hmm. So a lot of times people just make decisions about policies, but they don't really look at what is the pros and cons behind each thing. They kind of go based on ideology. And that's a very dangerous game to follow if you're only making policies based on what your preconceived notion without looking at the evidence. And we also had some chances to do some practical policy work. So I worked with the hospital on social needs in the community and trying to identify what problems patients faced in accessing care. And we came up with some solutions on addressing those issues.
Amazing. Do you see any, Michelle, you're frequently talking about cost-benefit analyses. Like, why do you do that when you've never been schooled in it?
Me?
Yes.
Yeah. No, I mean, let me ask Aamir this question. So when you talk about cost-benefit analysis, it's invariably it relies on some kind of formal modeling of what patients are, human beings are, how much they cost, how much they're worth. You calculate things on average, right? You divide by the average. You construct utility functions. I don't know much about it. I sound like I do, but I know enough but to be a little bit skeptical and wondering to what extent that actually captures the essence of what doctors and patients are and do. Did you have a sense that maybe the models may be nice and you can write papers about the models and certainly construct policy, but it veers off away from what patients and doctors are about?
Well, I thought one of the most useful things we learned was looking at the assumptions behind a cost-benefit analysis. And I think, for example, when you look at healthcare systems that do this regularly, so like the NHS or the Canadian system, they have certain cost-benefit analysis built into it, but people just take that as fact. They don't really look at the underlying assumptions behind that. And I think you bring up good points that when you put any kind of monetary value on inherent things like a person's life or things like that, you need to be very careful about how you're doing this analysis. So I think this course at least taught me how to be more skeptical about some of these models that we have.
How do you figure out what healthcare costs? How do you go about sorting that out? Meaning, like, like how much does it cost? How much does an EKG cost? How do you sort out these things?
It's really difficult, partly because there's so lack of price transparency in the U.S. system. But one of the ways you could consider it is willingness to pay. So how much are insurance companies, or pick your payer, how much are they willing to pay for this procedure? And that can be considered either a cost or a benefit if you're on the receiving end of that. That's just like one example, but it's a pretty complicated thing. I only took like the intro level course, so I'm sure there's much more complicated ways.
I think I know. I don't mean to. I'm not trying to put you on the spot, or I just as you're saying, the cost of things in healthcare have much to do with how much people are willing to pay. And so, the same thing that I buy, if I buy a treadmill machine, it may cost, $4,000 or $5,000, or it may cost me $12 a month to lease. I think that's the right number, actually. But the hospital system down the street, when they buy a treadmill machine, they have to pay like $30,000 for the same treadmill machine. So it seems incredibly challenging to, because I know what the urge is. The urge is, as you're saying, to try to quantify this and to try to arrive at the truth through, these various analyses that give you a nice yes/no answer in terms of, yes, we've set a threshold for cost benefit, and yes, this qualifies, but yes, but this does not. But I think getting the cost side of things right in healthcare today, given how the healthcare system is paid for, is incredibly hard, because there's, it's hard to figure out what exactly things are worth. Like, an
yeah, and like I said, one of the challenges was that it's very difficult to measure these things, and one of the big assumptions is that people cannot have a willingness to pay more than their income. So it's very difficult to estimate the value for the low-income people, because their income has a ceiling. They can't pay more than a certain amount.
Right. So isn't this
big assumptions that we can't use that a lot of times for treating certain populations.
Right. So are folks like me wrong to think that this is a whole bunch of hooey? I mean, this is like, the emperor with no clothes in terms of...
I think there is like some value in quantifying things, because I think the challenge is that a lot of these drugs that come out, for example, they might extend life by like a month or two, but cost like $5 million. So, I mean, there is a value judgment on how much you're going to value a certain time, but I think there is at least some benefit to having more information. But it is important to check your assumptions and to not take these things as gospel. You have to really be skeptical and kind of do your thorough analysis and understand what's going on.
Yeah.
When you did that master's program, was there any sense that the main goal was ethical, was to come up with a just policy? How was it framed? What was the overall? How was it framed? I'm curious to see how they frame it. I mean, because how would you distinguish one policy from another on the basis of what criterion?
Yeah, Chicago has been historically like very interested in the free market. And I think the way it was framed, at least initially, was that what is the most efficient policy, meaning like which has the biggest utility on aggregate. And the thing is, whenever you add regulations or like price ceilings or price floors, that accompanies some kind of loss. So the question is whether that loss will outweigh like whatever benefit you're getting from having that. And then you can look at the benefits of producers and for consumers. There was a little bit of discussion of ethics, but that was not the primary basis for which we evaluate policy.
Right. Although, the utilitarianism is an ethical framework. I mean, people don't think of it that way, but to say we want to maximize utility, why?
That's true. Yeah.
Then it'll be, because it's good. It's good. Quote unquote. But why is maximizing utility good if it means perhaps that some will be harmed and others will be favored, that sort of thing.
Yeah, one of the big challenges is that utilitarian is really the only framework that has some kind of quantitative basis to it. So you can add up the utility from certain things, and you are making assumptions when you do that. But for example, like deontology or like duty ethics, it's very difficult to quantify that in a certain way. So I think for that reason, a lot of economists love to use utilitarian as their framework.
Well, but because it also sets up this idea that like the physician or somebody, the population health manager, whether it be physician or not these days, should be somehow, our job is far away from the Hippocratic Oath, but which involves a duty to a patient, but rather it involves us being stewards of scarce resources. Do you see physicians as stewards of scarce resources, or is that would you say that's a general ethos that is kind of put out in terms of what's being taught?
I think it is. I mean, in some ways, we really are a scarce resource, because whether you measure that in terms of money or in terms of time, there's only a set number of physicians and there's a set number of hours they can spend taking care of patients. So every country has a different way of figuring this out. So some countries do it based on money. Some countries do it based on basically your willingness to pay, like fee-for-service based. So I think like you have to grapple with this reality that we really are a scarce resource, and there needs to be some way to evaluate that.
There's no question, but are we as physicians, are we supposed to be the stewards of these scarce resources? Is that what should we be trained to be stewards of scarce resources, which is very different than what has historically been the role of a physician? But I feel like that's changing now. And I think, and again, my sense is that it's driven by this utilitarian philosophy that is, comes out in, a variety of different economic arguments.
Yeah, I think there's some role for that in terms of the residency process. In terms of like how we train doctors and how we're thinking about managing patients. But there's always this balance between like, do you follow guidelines, like as you guys have mentioned many times, or do you kind of tailor it to the specific patient? And sometimes you're going outside those guidelines because it's ethical for that patient. I don't think anyone's teaching like blindly following certain guidelines, but I think there are certain things where the cost really is so excessive and not very beneficial. It is worth it to at least study to not do certain things.
Right. But did you see any conflict between, or how do you view, I mean, your fourth year medical student, did you actually take an oath, or was there a ceremony, a white coat ceremony at the beginning of your medical school or anything like that? How did you view that? And you think it's sort of a kind of nice, you know, for the sake of tradition, but at the end of the day, you know, you live in, you know, 2018, and the healthcare system you're going to be practicing, and all of that is sort of set aside.
I think
what's your view on that?
We gave the Hippocratic Oath, and we were required to like kind of talk about it. I think now there's kind of a shift where there's a big challenge of like burnout and doctors being really unhappy with their jobs. So I think our medical school tends to focus on like a work-life balance. So you need to do the best for your patients, but also maintain your own kind of mental sanity and mental health.
Right, but I was trying to tie that to the what you learned in the in your policy masters, meaning on the one hand, as a doctor, if you take that oath, and I'm not sure what form of the oath, because you know there are many nowadays, you know, a pluralism of oaths. But was your oath compatible with a utilitarian approach to healthcare policy, or was your oath in conflict?
It's a tough question, because I think one of the critiques of utilitarianism is that you can basically do anything to somebody as long as it increases aggregate utility. So right. I could go murder someone and harvest their organs because it'll help 8 people. So I think that it doesn't really address this issue. It's kind of agnostic on that topic. But we did have a class on ethics later on in the curriculum, at least in the medical school, and we did talk about some of these issues.
Okay, fair enough. And so you took your master's at the University of Chicago, was it taught by in the economics department, or is it a separate department, or?
So it's its own school, but there are a lot of economics professors that used to teach courses there.
Okay. And, you know, University of Chicago is known as being, in general, pro-free market, but it has a very utilitarian approach to the free market. In general, which I disagree with, is that they will tend to be, as you said, you know, primarily driven by efficiency. Although, you know, interestingly, Milton Friedman, who was at the University of Chicago, I think is pretty good on healthcare for the most part. I don't agree with him on everything, but on healthcare, he's actually quite good. I mean, he's really a slasher of all regulation. I'm not sure that what he would have thought about trying to devise efficient policy. I think he was against licensing. Without licensing, you really cannot have any policy whatsoever, because licensing is the linchpin of the healthcare system. It's how you're able to identify who the doctors are, and then you can, you know, there are pawns that you can manipulate. But without licensing, it's a totally different ball of wax. Good. So, at any rate, so you have this training now in public policy. I can really see that it would be sort of enriching, that you're going to start, you know, your career as a resident. You're not going to be completely naive the way I was. Certainly, I had no clue whatsoever, and I was completely at the mercy of whatever the system was imposing on me, until, you know, it took me years to figure that out. So you're better prepared, but you're going to start a program in dermatology. And are you following a straight dermatology path, at least for the time being, for the next few years?
Yeah, I'm planning to do direct dermatology. Although, like, when I'm looking at interview opportunities and residencies, I'm looking for programs that support these other interests that I have. So programs that let you explore your policy interests, or let you kind of pursue advocacy for underserved people, things that I was doing in college and med school. So it kind of guides my search process, but at the end of the day, it's still a match. So it kind of depends on what happens.
Right. And how are you optimistic? How do you view the future? Many doctors, you've talked about burnout, so there's a lot of burnout in medicine. Do you feel you understand things enough that you can navigate the system and avoid the issues that some of our colleagues are facing?
I think it's possible, but there's a lot more burden on the practitioner to now look for these programs. So there's many places that are highly malignant or doctors are very unhappy with their job. And I think in the past, maybe this was something you didn't really think about, but now as I'm looking for the future and looking for jobs, that's something I'm really serious about is, are people happy? Do people enjoy coming to work? Like, that's a real concern now.
Can you figure out what makes people happy?
I think you get a sense of like when a lot of times these residency dinner, they have like pre-interview dinners, so you can meet with faculty and residents in an informal setting. And I think you can get a sense of how people talk about their job, or they if they seem very burnt out or they seem depressed going to work. That there's subtle things you can pick up on. So far, I've never experienced a place like that, but I mean, hopefully, I won't have to.
Yeah, I wonder. It's an open question, I guess. Why do physicians burn out? And because I think we have trouble defining the problem. And if you don't define why that's happening, then you come up with solutions that don't really work. So, I don't know. I don't know if you, as a resident, can, if you have colleagues and stuff that are super unhappy and, why, not just in dermatology or not just in folks that are going into whatever, like, how do you have a sense of your class and whether or not they're relatively optimistic or are they despondent? Is it only the dermatologists that are very happy and all the people going to family medicine are not? Or
so to be clear, Anish, Aamir is still a student, so he has.
Yeah, no, I know.
Okay.
Yeah, sorry. So I was saying with your medical school class, right?
I think there's a general sense that everyone is picking a career that they're interested in, but certain careers are more likely to have a high percentage of burnout. Obviously, dermatology, like radiology, these professions maybe have less burnout, but it's still a valid concern for us to look for programs that have.
So why is that? Why are dermatologists and radiologists happier than family medicine doctors?
I mean, I've read a couple of studies on this, and I think the number one factor for burnout is documentation. So I think that's why like a lot of hospitalists or EM has high burnout is because they're just constantly filling out paperwork, and the EMR is not really suited for a lot of the jobs that they're doing. I know for derm, it's mostly outpatient, and I've seen a lot of doctors hire a scribe to just do their work for them. So they have to see a couple more patients, but they're fine with that trade-off because they get to do what they actually want to do.
Right. EMR, Epic,
Mm-hmm.
is the problem. So, I mean, in general, I've found that that it's not necessarily how much you work or what type of EMR you may have, but it has a lot to do with autonomy and.
Definitely, yeah, that's a big part of it too.
And so, I get the sense that dermatology, ophthalmology, they are high-paying positions. They are high-paying, specialties that still allow you to sit at the upper rungs of society's elite and buy nice cars and nice houses and nice neighborhoods. But in addition to that, the folks work a lot, and even though they may be on call more or whatnot, on call meaning have spend many days working, not necessarily that they have to go in overnight for stuff, but that regardless of that, it's the ability to set up independent private practices still exists to a much wider degree in the world of dermatology, in the world of ophthalmology, or some of these other, plastic surgery, much more so than it does for primary care now. So, and I think that's a big reason why folks are burning out. It's like, no one wants to work for the man, and so the less you have to work for the man, and the more control you have over your schedule, even if that means you have to work a lot more, the less likely you are to burn out. But
Aamir, can you go back to before starting medical school, while you were applying? What was your vision of what life as a doctor would be, and to what extent it has changed during your medical school years? Did you know you wanted to be a dermatologist from the get-go? Are your parents doctors, or did you have any exposure to medicine from before?
Yeah, so my dad's a neonatologist, and a lot of my parents' extended family on both sides are doctors. So I was at least aware of that different types of practice. Like I saw people in private practice and academic, surgeons, internists, all different types. So I didn't really go in with any clear goal of what I wanted to do. I volunteered on an ambulance during college, so I'd maybe considered emergency medicine, but I was willing to explore like different options. And I had no real concept of what kind of practice I wanted to have. Like my dad works in an academic practice, so I kind of saw that as the default one. And if you go to a big research school like U Chicago, most people do end up going into academics. But I'm open to other opportunities now. At least now I'm more aware that there are other things that you can do.
Okay. And what about? I love to think about the nature of the doctor-patient relationship. Did you? And perhaps you didn't have the same sort of naive, I mean, so-called naive view of the doctor-patient relationship that I had when I started medical school. But I really wanted to, my essay was I want to help people, that sort of thing. And it was actually genuine, right? And I'm not going to say that I turned into a cynic, but in a way I was forced to sort of recalibrate my expectation of what my sense of professionalism was through the years. Did you see that going through medical school and now that you're coming out of it?
Yeah, mostly because when I heard stories about my dad and some of his family living in India, the way they practiced medicine was very autonomous. So basically you kind of made all the decisions. Patients knew you directly by name. You'd make house calls occasionally. But in the United States, that's really rare, I think. Most people kind of work for a big practice or they have some kind of big group that kind of coordinates all together. So it definitely felt more of like an impersonal thing, which I think is that we're kind of talking about in this podcast a lot. That seems like a less and less common thing nowadays.
Okay. I want to touch also on something that seems to be an interest of yours, and I wonder if we can talk about it sort of broadly in the context of medical school and diversity in medical school. So you write about interfaith dialogue, and do you write about it in the context of healthcare and medicine, or just generally in the context of being a citizen of a diverse community?
In both contexts. I think I got into it just based on the fact that I lived in an area that was pretty diverse, so I had friends of many different backgrounds, and our family is Muslim, we practice, so it was kind of a natural thing we talked about a lot, and I realized that a lot of religions have very similar values about service and ethics, and then as I kind of went into medical school, I realized a lot of those values are very applicable to medicine as well.
Okay, and so do you feel that there's more, or how do you view the question of diversity? The reason I bring that up is it's not in the context of religion and spirituality, but on this show we've had occasion to talk about how there seems to be diversity for certain things and not for others, right? There are something, people may preach diversity, but so long as you don't, you're not too, too diverse, or there's a standard view of diversity, it's sort of a paradox. And how did you view that in medical school? Did you have a sense of that, or do you think that no, things are moving in the right direction? That things, there's a genuine pluralism of ideas and opinions on campus and in medical school?
I think in the past, people tended to view diversity in like one-dimensional terms. So your race, your gender, your religion, your orientation, those kind of things. I think now people have started to realize that you're not just one identity in isolation. So you have multiple identities that kind of interact together. And that's what we call like intersectionality. That's a very common word now. I think especially now people are starting to even expand that to other areas. So what kind of medicine are you interested in? Those kind of other aspects. So I think in general, I've seen medical school kind of becoming more inclusive of different identities.
Okay. Let's say, and I'm not sure what view you hold, but let's say you held a view in medical school that was against abortion, for example. Would that be sort of embraced? And you say people would say, "Oh, great, we'll accommodate you in your rotations, B, and let you do that."
I think that specifically would not be would be accommodated. Although it depends on the institution. So I went to Georgetown for college. Georgetown's a Catholic school, so I think they might be more accommodating of those kind of things. But if you go to a secular, even like a public institution, I think there's different assumptions on what you're comfortable with doing. Although I do think nowadays medical schools are aware that the classes that are coming in are more diverse. And if you made your views known to the administration, I think they could work with you.
Right. Very good.
Does anyone in medical school wear a MAGA hat?
I have not seen anyone doing that.
I see. Do you think there are MAGA hat wearing people that are they're just too scared to do that, or I mean, is this
Probably. I mean, U Chicago, like most academic places, I think is more in the like left leaning, just based on
yeah?
majority. So if you do hold a minority viewpoint, it is more difficult to voice your opinion. But our school actually had a discussion on this particular topic.
Oh,
We
really?
said we know that there are people who might be concerned that their opinions are not in the majority, but we should make this like an inclusive environment for them as well. That's kind of an ongoing work in progress for us.
Oh, I see. Interesting. Yeah. So, I mean, do people believe? I guess people don't voice it because they think that there'll be negative repercussions to them. Is that right?
Occasionally, I mean, I've gotten to debates with my like single payer advocate friends, and
Mhm.
I think they might have some negative opinions of me based on that, but I'm fine about voicing that opinion even if it's not the majority.
I'm trying to think, like, whether folks, it's weird. Like, everything is political these days, right? And so if you have a position on kneeling or not on the national anthem, that could go very badly for you if you voice that in any any context of a peer group that's evaluating. So, it's strange. And I'm trying to think, I don't know about you, Michelle. I mean, Michelle, went to school in the 1940s or 50s, so it's a very different time. But here we have three different generations here: Michelle, me, and you. So I don't know. So I'm trying to. I feel like there was. I at least didn't feel it, and maybe it was because I was part of the majority at that time. And but I feel like I had vigorous debates with folks on the other side, and there wasn't this idea that, like, if you said something that was on a different side, you were immoral.
Yeah, honestly, that was one of the reasons I like going to policy school is that
Yeah.
people who come to this school are really serious about we want to look at the best policies. Like ideology is not as important as like looking at what's actually beneficial for people.
No,
I
but the
think
problem.
medical students are less likely to think that way.
But the problem is that what's actually beneficial, the metric that they're using to decide what's beneficial or not, is whether or not there's evidence for it or not. So I don't know how many times on whatever social media that we'll have some debate or some about some policy or something that's obvious, like like I think I said once that Medicare Advantage plans have narrower networks, and therefore the care they get is for somebody who's sick, I don't recommend that you have a Medicare Advantage plan because they have a narrow network of folks, and if you need a specialist that's here, or if you need IV iron, say, it's likely that it's going to be harder for me as your physician to get you that because you have a Medicare Advantage plan. That's obvious to me because I'm practicing, right? But the policy folks, when I'll say this, they'll say, "Oh, there's no evidence, as far as I know, AFAIK. There's no evidence to suggest that Medicare Advantage plans are worse than traditional Medicare." So, whoa, I don't care what you say.
But you could also say there's no evidence to suggest they're better than the other plan, right? So you could kind of go both ways on that.
No, you can, but of course, unless it's truly worse, policy makers make policy. So my point is that there's this illusion that there may be this illusion that policy folks or public health folks or whatever are very objective and empirical, but I think everyone brings a certain ideology, and certain ideologies are made more robust, I should always say. So.
I think that's a fair point. I mean, I think the policy people at least are more honest about some of their biases going in. So they'll say, I learned this way, so this is how I think. I think in medical school, like, we're not really trained in policy. We're more trained for medicine and ethics. And I think people are not as willing to admit that that is a bias in how they think.
Interesting. Yeah.
Well, Aamir, do you have any questions for your professional father, Anish, or your professional grandfather, me? Not that our advice is, ever fruitful or wise. But what questions do you have? We've had sort of, speaking of diversity, fairly diverse path, and I'm wondering if you had any comments or any things you wanted to ask of us.
I mean, where do you see medical students playing into policy going forward?
If I had my druthers, I would ban them from getting involved in policy. So you skipped from my grasp, Aamir. I don't know. Policy is obviously here to stay, but as I said, I'd like. I mean, I think it's fine for people to get involved in policy and say we need less of it, and to make the case that there are too many policies, that it doesn't actually ever produce. It may on paper produce some efficiencies, but it's never really the case. Or that the ethics. I think I'd love to somebody to argue on a alternative ethics for policy that is not utilitarian, and do it eloquently, because people respond to ethics. For even policymakers, if you bring up ethical arguments, they sort of freeze. So I think it'd be good for medical students to retain what you mentioned is some of their training to think about things ethically, retain that and bring that conversation to the policy sphere, to say, hey, wait a minute, that if you introduce policies like that, it's going to be a real distortion on the essence of what medical care is about, and that's not fair, and that's step back. Or let's decentralize it a little bit. Okay, let's have policies, but maybe not have a policy for 300 million people. Maybe we'll have a policy, we'll let states do their own things. There's no reason why the federal government should be involved in that sort of thing. So that's what I think. If somebody wants to be involved in policy, which is fine. I mean, I'd like that sort of voice, to be heard. Or that sound to be voiced.
Why do you think medical students shouldn't study policy?
Because I think all policy, I mean, it's almost the essence of policy is contrary to the doctor-patient relationship. I think to me the optimal efficiency is to leave the doctor and the patient alone, and anything that interferes with that is actually a net negative. But it's a different concept of utilitarianism, or it's a different concept of value, right? So for me, the value cannot be objectivized and written in terms of utility functions and that sort of thing. So I don't believe in that whole thing. So that's why I want to caution medical students from going into it. But if they do go into it, because it's at some level it's necessary, since it's not going to go away by itself, right? So I can see a value in getting involved in policy or in politics, but at least having that perspective in mind, so that you try to, tear pages off the book of policy as opposed to add to it.
I mean, the doctor-patient relationship is just one aspect, but then we have all these other problems like opioids or drug costs. I mean, I think there is some value to knowing what policies are existing. And taking away regulations is also making policies. So I think it is beneficial.
It is correct. But I think it's, I mean, why do we have these? I mean, if you look at it historically, and that's, I mean, I have an interest in history, because unless you view things historically, it's actually very hard to understand or separate out. Because now it seems to be, you have the doctor-patient relationship on one side, but then you have all these other global social problems on the other side and sort of thing. But if you go back historically and go back decades and decades and decades, then you see, at least in my mind, that it's usually policy or government intervention that starts to, allegedly want to improve the greater good, that with its unintended consequences starts to destroy things, to make things worse, to create new social problems that didn't exist before. And you can trace them back, but it requires having some kind of a historical perspective, but also having certain principles, which I mentioned, with which I disagree, which means that I think the question of drawing utility curves is not really a good model for what human beings are, right? So viewing it that way to me is helpful. And I'd like students to understand that and to be involved. And they need to be. I don't have the facility to talk about utility curves the way you do and the way you've been trained. So I think they need to have that facility. But at the same time, they need to really fully understand the alternative and embrace it. At least that would be my ideal. Embrace it so that they can be more effective promoters of good medicine, which is ultimately what I want.
And I think you're going to get it wrong. I think you're going to get it wrong when you approach this from a policy-centered approach. I know the policy folks will hate that and be like, "Oh no, it's it's all about the patient." But you can't understand the opioid epidemic without being somebody that's treated patients. that's watched patients overdose, that has had, you know, a therapeutic relationship, that even if you're not a doctor that manages addiction, if you're a doctor that simply has a practice that sees patients coming in that are seeking drugs and sees, you know, there's so much that's lost when you don't have that. So I mean the type of policies that are being made right now, for, you know, you brought it up, about the opioid epidemic, are just abysmal and stupid. And the problem is that you won't realize it. The policy folks won't realize it until 5 years down the line, when something else bad happens because of some stupid policy that they've made. You know, the freaking, you know, apparently the Philadelphia City Council is debating this last week about regulating pharma reps more by making them register and do training. Every pharma rep, not just the opioid pharma reps, every pharma rep must now register with City Council and pay $500 and maybe go to training, and not, you know, they won't be allowed to have any lunch $7 sandwich inducements because of the opioid epidemic, right? You know, it's like, what? There's 0 point to that. This is just some virtue signaling idiot politician.
Well, in this case, do you see doctors who know policy filling this role? So a doctor who knows policy can go to council and say, based on what you guys are doing, this policy is bad. I've studied this. And I also treated patients.
No, that's the problem. The problem is that, you know, they don't. Yeah, the folks that the politicians go to are the policy experts, the people that are experts in policy. And the only reason they're experts in policy is because they have a title. You know, they have a title at some academic university, and that is not adequate and not enough. And, you know, there needs to be a whole lot more listening to a bunch of individual docs that are busy, you know, in working with addiction. Or even if those folks are too busy, talk to me. Even some dumb cardiologist like me knows that whatever idiotic thing you're doing is pretty stupid. But and this has happened.
Policy school isn't just like the mathematical, like utility curves, drawing things. A lot of it is like leadership and advocacy skills, writing skills. I think these are things that are useful when you're trying to advocate
No, that's all.
Trying to contradict things.
No, that's fine, but it has to be grounded in experience, I think. And I think the mistake is that too much of this is not grounded in experience. The mistake is that, you know, if there isn't a paper that says it, it doesn't really exist. We don't know. How do we know? I mean, so I think over and over again, I mean, you know, I don't know. We can look at all this policy failures that have existed that we've written about, whether it be public reporting, like, oh, public reporting, let's do that. And
there's actually a class at UChicago called "Good Intention Policies Gone Wrong."
Yeah,
it's interesting. They look at this exact issue. People that like, they knew what they were doing, and the policies ended up having like the opposite effect.
Yeah, I just think, you know, they're unfortunately not, you know, whatever. I mean, I think I'll keep repeating myself, but this whole, you know, you have to have a clinical experience, something that grounds that, and I think that's perhaps more important than coming at it from the other side. At the moment, at least, that's what I think. Anyhow. Well,
Aamir, thank you very much for spending this evening with us. I know you're busy and you're you know, preparing for all your interviews, and it takes a lot of time. And we're very happy that we had a chance to chat and to view things from your perspective, because, you know, it's a little bit of the echo chamber. Anish and I.
Right. Well, happy to be here. Thanks a lot.
Thanks,
all right.
Alrighty.
Take care. Bye bye.